India from 1990, when we talk about, there's a fourfold increase in the obesity. It is postulated by 2050, we would have at least 450 million people with obesity.
In your practice, do you see more men or women who opt for bariatric surgery?
So if I go with my data, I would say 75% of my patients are females and only 25% are male.
Really?
But there's a catch to it. Now there are so many husband-wife I've operated.
Oh.
The wife will always opt for first for the surgery, and the husband will always wait to see the results and then go for the surgery. So this is what has happened in a couple of our patients also.
Do these surgeries alter your metabolism?
So when you talk about metabolic changes, there's a good amount of change in the gut hormones also. There's good amount of change in the gut microbiota.
The lady who you operated on, who was 235 kgs, how much has she lost? Has she maintained?
So this lady came from Liberia. She was only 23 years old.
Why would a 14-year-old need surgery?
No, so that's what childhood obesity. When I talk about this patient, she was only 14-year-old, weight of 133 kgs. There is good important mention here about the deficiencies, because patients, when they undergo bariatric surgery or for any matter weight loss surgeries or weight loss with medications, deficiencies can occur. The medicines have created an awareness in a very positive way. Nobody is talking about the side effects of the medicines. Patients who have history of thyroid cancer, which is the medullary thyroid cancer, if the patient has any history in the family, we should not be starting with the medication. You have to understand that the day you stop medications, weight regain is also going to be there.
Discussions on weight loss never lose relevance, and the topic is always trending for every age group. Though body positivity is very important and there are many advocates for it these days, controlling obesity is not only about vanity, it's about your overall health. Obesity is a chronic metabolic disease which carries many risks. To discuss different approaches to weight management, including weight loss surgery, we have with us Chief Metabolic Surgeon from Jupiter Hospital in Thane, Maharashtra, Dr. Prashant Hansraj Salvi. Welcome on Buzz by the Bay, Dr. Salvi.
Thank you, and pleasure is always mine.
You are the Chief Bariatric and Metabolic Surgeon. You're a consultant as well. The topic of weight loss and fat loss never gets old. So first off, briefly tell us what a metabolic surgeon does.
So a metabolic surgeon is a surgeon who does surgeries for weight loss. Now when you do surgeries for weight loss, there are a lot of other metabolic changes also happen. Now when you do these surgeries, the most important direct comorbidities because of the weight is type 2 diabetes. So when you do these surgeries, there's a good amount of resolution because of the comorbidities. There's good amount of resolution of hypertension, cholesterol, fatty liver, all those things reverses. So it's not basically just weight loss. And when we do sleeves or RYGP or a bypass, all those surgeries also create a lot of gut microbiota changes. There's good amount of resolution of insulin resistance, and that is the reason why these changes help in resolution of diabetes, hypertension, cholesterol. So overall, the metabolic health of the patient improves when you do these surgeries, and that's what we do as a metabolic surgeon.
So you've done over 2,000 surgeries, bariatric surgeries, and I'm going to ask you later on the different types of bariatric surgeries. So you're saying it's not just about dropping your weight on a scale, it's about reversing type 2 diabetes, lowering your cholesterol, improving your fatty liver condition. So there are a lot of, you're talking about the benefits that come, and this overall your metabolic health improves. So essentially your metabolic health is the rate at which your food is converted to energy.
Right.
So do these surgeries alter your metabolism?
So, so when you talk about the metabolic changes, there's a good amount of change in the gut hormones also. There's good amount of change in the gut microbiota. So if you see more of these gut microbiota, such as Faecalibacterium, then there is Muciniphilus. So these are the organisms, or these are the gut microbiota, they increase, and because of which there is good amount of resolution of metabolism, there is good amount of resolution of diabetes, and all these changes, they happen as and when the surgery is done. So when you also talk about GLP-1, PYY, these are the gut hormones. So when you do surgeries, these hormones rise, and that is the reason where you achieve early satiety, that gives you good resolution of insulin resistance. There's something called as a hunger hormone. Now, ghrelin, which is talked about a lot, ghrelin is a hunger hormone. So when you do a sleeve gastrectomy, the ghrelin is completely taken away. Even for a bypass, the ghrelin is completely taken away. So the patient feels full immediately after, with even a small quantity of food. So all those changes, they happen, and that's how the resolution occurs. And that's why the metabolism increases.
Okay, so your metabolism actually increases. That's what many people want, because as we age, especially for women with so many hormonal imbalances, the metabolism slows down considerably.
Correct.
And these days, everybody is talking about gut health and taking probiotics to improve the gut bacteria.
Right.
So that's a positive effect, and you totally cut out the ghrelin, which is a hunger hormone. So a person doesn't feel hungry.
So even if the smallest amount of food, they are full, because the signal to the brain is not going, which is because of the ghrelin.
Okay. But these are short term, right? Reversals. I mean, it's not that you have a surgery once and this will last forever.
No, so I would rather say that surgery is not a shortcut. If you consider surgery as a shortcut, then you will not have that desired results also. The backbone of any for that matter, even diet, exercise, medicines, weight loss surgeries, the backbone will always remain a good lifestyle balance, a good amount of physical activity. These are the two things which will never change. So in spite of doing a surgery, if your lifestyle is not changed and you are used to having all high calorie food, not used to doing any exercises, you are tend to come back with weight gain.
Okay, so it essentially gives you a second shot at life.
Yeah.
If you're grossly obese, and I want to come to that, who is a candidate for this. But how does someone measure their metabolic health? What are the tests one should do?
Now for the metabolic health, see, like you said before also, metabolic something which is how the body processes the energy from the food and how does it store, and it maintains a balance for your sugars, your blood pressures and your cholesterols. Now, how do you measure it? So you must have seen people who are lean, but they have a pot belly. They have good amount of adiposity over the abdomen. Now, these are very vulnerable patients for cardiac and diabetes also.
Like visceral fat?
Yeah, visceral fat.
Yeah.
More of the abdominal adiposity. Now, if these patients, the waist circumference is very important. Now, if the waist circumference is more, and even if the BMI is low, these patients can be a candidate for.
So even if your BMI is
yeah.
low.
So we have the most important criteria is the BMI, the body mass index, which is a very simple formula. It is about your weight in kilograms but divided by height in meter square. But overall, if you see, that will not calculate your fat percentage. It will just give you the BMI whether you are in normal BMI or not. So the normal BMI ranges from 18 to 25. Now, if you go up on the BMI and that you reach to 29.9, then it is overweight category, beyond which 30 and above is obesity. But see, for a patient who is healthy, he has a good amount of muscle mass. Now that patient's BMI would be higher. I mean, he's still healthy. He's not vulnerable for any diseases. So BMI as such is good for an overall assessment. But waist circumference, then your waist to hip ratio, your waist to height ratio, all those criteria are also important when you want to define obesity or when you want to diagnose obesity for that matter.
So BMI is not a foolproof kind
Yes,
of
100%.
category,
Yeah.
criteria for obesity. So what should your waist to height ratio be?
So when you talk about waist to height ratio, if the waist to height ratio is more than 0.5, then it is a risk factor for diabetes and cholesterol issues and even for heart diseases. And for the matter of hip to waist ratio, if it is more than let's say 1, or in females if it is more than 0.85, then again they become risk factors for cardiovascular diseases.
Okay.
So these are some criteria based on which we can assess whether the patient has good amount of visceral fat, because only on BMI criteria you can't judge someone.
Yeah, because someone's muscle mass.
Yeah, someone's muscle mass is high and then you can't label them as a higher BMI patient.
Okay, can you give us some statistics for obesity in India? And in India, it's above 30 BMI is considered obese, or what is the benchmark?
Correct. So the World Health Organization has devised a criteria based on the BMI. So if the BMI is between 18 to 25, that is specifically 24.9, then you are healthy. But if your BMI starts from 25 and goes to 29.9, then you are in overweight category. And above 30 is defined as obese criteria.
Obese.
So above 30 is obese. And there are different criteria, different classes of obesity.
Yeah.
If you are above 50, then it is super obese category. So these criteria have been given by World Health Organization based on which we classify patients for obesity.
Okay, fine. So some statistics for India, would you be able to give us?
So if you see India from 1990, when we talk about, there's a fourfold increase in the obesity. Because right now, as per the National Family Health Survey of 2019 to 21, if you see that the adult male have been grown from 18% to 21%, and for female adult obesity it has gone from 20 to 24%. So if you see 236 million people are fighting with obesity and overweight right now, and it is postulated by 2050 we would have at least 450 million people with obesity. And this is just in adults. When you talk about childhood obesity, you would be surprised to know that 5 to 8.8% school children at this point of time are obese. And it is also said that by 2030, 27 million school children would be obese. So it's really important to understand childhood obesity is a big problem which we would be facing in future. So we need to act now.
And how do we act? Is it for children? It can't be surgery or Ozempic, right?
Correct.
It's got to be diet and...
No, so diet for a child, it is really difficult.
Exercise.
So amount of physical activities that kids do. Nowadays, you must have seen the amount of workload they have. Even in school, they come home and they just sit on the maybe laptop, or they have to do some work online. The amount of people on the playground, you would be seeing very less. And both the parents are working. The child is not exposed to that much of atmosphere. Now you see parents ordering food online, and the child will also see the same thing. If the parents do not exercise, the child will feel that is normal. They won't be able to even initiate something from that sort. So if the parents have a good lifestyle, they do regular exercises, they have a good control on the diet, the child will learn the same thing. And amount of ground exposure the kid will have, it will obviously help to curb obesity.
Okay.
And the fast food, I would rather mention that as well, because the processed food has gone crazy, and people are just hooked to it because our lifestyle has become so fast, and we order fast food, but we have never understood what is the content in that.
You've operated on a very young person of 14
Yeah.
years of age, and I want to ask you your case studies later on, but firstly, who is a candidate for bariatric surgery or metabolic surgery?
So we have Aussie guidelines. Aussie is an Obesity Surgical Society of India. We have international guidance also. So based on that, we define the criteria. Now, if the patient's BMI is 32 and the patient has diabetes, cholesterol issues, hypertension, fatty liver, NAFLD, so any two of these criteria if present, that patient can be taken up for surgery. If the patient's BMI is above 35 and without any comorbidities, that patient again can be a surgical candidate.
Do you see with like drugs like Ozempic and Mounjaro in the market, less people are opting for bariatric surgery now?
No, so I take it a different way. The amount of awareness these medicines have created, that is phenomenal. Now, 3 years or maybe 2 years down the line, people were not talking about obesity, people were not talking about weight, but the amount of awareness these medicines have generated, that is really, really good. A lot of people are coming to my OPD just to understand what are these medications. So surgical will never go down, because see, surgery and medicines, they have to work at par, maybe at together. If they work together, this will give good benefit to the patient. All patients cannot undergo surgery. Neither all patients can undergo medical management. So it's always hand in hand. And if you ask me the number of cases gone down, no, not exactly. See, for a patient of 150 or 200 kgs, these medications are never going to help.
Not going to help for
not
someone.
Not going to help. So they will require bariatric surgery.
And
so
after that, can they go on Ozempic?
They can, yeah. So that's what when I speak into those forums, I always say that medicines and surgery will always have to go hand in hand. Now, for some patients who are requiring surgery, but for some medical issues, they are not able to come under the knife, these patients are put on medications. They lose at least 5-10 kgs before the surgery is done. That helps in me recovering this patient faster after the surgery. Now, when the patients come back with weight gain, like we defined, we defined obesity as a relapsing disease. Now, even if the patient has undergone surgery, 2 years down the line, they come with weight gain. Now, these medications are helping us to again probably not put forth the patient for revision bariatric surgery. So these medications can be given before the surgery, after the surgery as well. So drugs, for that matter, the day when you stop those drugs, the weight is going to come back. See, how are these drugs acting? They are decreasing your appetite. Now, when you stop those drugs, the appetite is going to come back and you're going to be asking for food again.
What about things like, instead of taking this extreme step of surgery, I'm not trying to run down your profession in any way, but I'm saying that what about things like intermittent fasting and all? Can't they help people lose 40-50 kilos?
No, so I'll give you an example. Let's say someone has lost 10 kgs or 15 kgs because of intermittent fasting. The friend of that person will never lose the same amount of weight because everybody's metabolism is different.
Okay.
Now, to even start with intermittent fasting, you have to understand what is your serum insulin levels from the start, whether your insulin is spiking at that time or no.
Okay.
Because everybody will not be benefited with intermittent fasting. But what I always say is, any diet for that matter, which you only can decide. A person has to decide his own diet, thinking how much calories they are consuming.
Yeah.
If that one particular diet is able, he is able to follow or she is able to follow for a year together completely, that's the diet. Because see, any crash diet for that matter, intermittent fasting or any for that matter, you do it for 2 months and leave it. What will happen? You will start gaining weight. But when you gain weight, you gain more of your fat mass. The muscles don't come back, and that is where the entire thing goes wrong.
Okay.
People who are on intermittent fasting have come, they have come with gallstones also later on. So it always has to be supervised. Whichever thing you do, always has to be supervised.
So they've come back with gallstones after
Yes,
extreme
yes,
intermittent
yes, yes.
fasting.
So gallstones can be because of surgery also.
Yeah.
Because your diet goes very low, you are not able to eat much of the food because that is what is required. But your bile stays in the gallbladder for a longer period of time. It goes into stasis and then they can form stones.
Okay, so basically whatever you do has to be sustainable, and
Yes.
even if you're going for surgery is more in extreme cases where nothing else is working for you, where you have a lot of metabolic diseases, you're grossly overweight, and then you come and take a second shot at life, but you still have to maintain it with your lifestyle. So in your practice, do you see more men or women who opt for bariatric surgery?
So if I go with my data, I would say 75% of my patients are females and only 25% are male.
Really?
But there's a catch to it. Now there are so many husband-wife I've operated.
Oh.
The wife will always opt for first for the surgery, and the husband will always wait to see the results and then go for the
okay.
surgery. So this is what will
Clever.
happen in a couple of our patients also. But the amount of people coming to the OPD, the males are more as compared to female. But probably because of family restrictions, or I have couple of incidences where the females are not ready for the husband getting operated for obesity.
Oh.
So, but if you see an overall data, a lot of females are operated more in my practice as compared to males.
Interesting. Can you tell us, the age of the patients in some of your cases? Because you've operated on a young woman who was 235 kilos, the heaviest woman in Thane
Yes,
district, but she
right.
was Liberian.
She was Liberian.
Can you tell us about
So,
that?
if you see the age gap between the patients I've operated, so I've operated a youngest, which is 14-year-old.
Why would a 14-year-old need surgery?
No, so that's what childhood obesity. When I talk about this patient, she was only 14-year-old, weight of 133 kgs.
Oh my
I really respect the parents because these parents were so up for something for the kid, because at that early age, her sugars were unstable, her cholesterols were going high, her cycles had completely gone haywire. And the amount of depression these kids have, because they are not able to move out, they are not able to go around, school was not regular. So these parents, when they came to me, I was really happy that okay, these are the parents who are actually interested in doing something for the kid. And when I talked about surgery, they upfront got ready because they wanted something for the kid. So age is never a restriction. The problem because of the obesity, what they have, that is always a priority. Now I have operated a 70-year-old also female.
Oh.
So at that age, the problems because of obesity were more than the age. So we can operate from 16 to 75 years of age without any restrictions as such, but provided the surgery has to be benefited more than the problems which the patient has.
So this 14-year-old girl, okay, she was obviously missing school, you're in depression, all these things come along with obesity. How much weight did she lose and has she maintained it?
So she right now has lost around 40 kgs or so. It's
Okay.
been 6-7 months now post the surgery, and she would be losing weight. Provided probably if she goes haywire. See, they are children. Children are, it's very difficult for them to restrict to one particular diet. Now, we do have an option. Let's say 5 years down the line, the kid comes back with weight regain. We can always put them on medications also, and also we can do a revision bariatric surgery. So there's a scope always. Yes, as a revision bariatric surgery also can be done if the kid comes back with weight regain.
But then surgery after surgery for such a young child.
But you imagine a patient's plight at 13 years or 14 years of age with that many problems, with medicines for diabetes, with medicines for hypertension, cholesterol, that is detrimental. So before they get into that vicious cycle, we have to take them out.
Okay.
And that is where the first hit, even for medications, what they say, the criteria for medications are quite less. The BMI criteria for starting medication is 26 and 24.
Oh.
What everybody says that before you actually get into all those problems, prevention is always better than cure. So you prevent obesity.
Okay.
See, the fact that we are talking about it is spreading awareness.
Yes.
the amount of people are aware of obesity and its problems, they would try not to go in that direction. But people who are already there in the direction, we have to get them back by means of surgery or by means of medications.
So this, the lady who you operated on, who was 235 kgs, how much has she lost? Has she maintained?
So this lady came from Liberia. She was only 23 years old and irregular cycles, not able to walk. 235 is a huge weight, and when she came to us, we explained about the bariatric bypass. We did a bypass for her. She's lost 50 kgs. Now she's 177. It's been 7 months now post the surgery, and she would be coming back in the month of November for the follow-up and endoscopies also. So this is the journey which has just started. It's not going to be restricted to 50 kgs.
Yeah.
She would be losing good amount of weight. So over a period of 1.5 years to 2 years, I expect her to be at least around 120 and 120, that range.
Okay, and that still seems a lot, but it's a world of a difference for a person who's 235. You
100%.
can probably at least get up and walk.
Yeah.
You know, I mean, otherwise you probably need help getting out of bed.
So for that, I would give you an example. Recently, 15 days back only, we operated a lady. She was under a chest physician in my hospital. She was admitted. I got a reference for the patient. So we couldn't measure the weight also, because that lady was not able to stand. Since 2.5 months, she's not moved at all. She's not even stood, because she feels that whenever she stands, she'll fall down, she'll break some leg. And when we tried to make her stand, her legs were shivering because of disuse atrophy. She has not moved her muscles at all. So when I saw her, I saw that she's already on medication. She was on Mounjaro. For 2 months, they tried with medication. Then I said, no, this lady definitely deserves bariatric surgery, because these are the candidates who would definitely benefit.
That's great. You're giving them a new lease of life,
Yeah.
and that is wonderful. Okay, I want to later on come to a few of the risks, but I want to narrate one story of my real brother,
Sure.
who was about 140 kilos. He even consulted a bariatric surgeon, but he had a lot of other health problems, and including heart problems, and had a stroke at a very young age because of being overweight and high sugars. So he decided against bariatric surgery. He didn't even go on Ozempic. He did intermittent fasting. So this is a very extreme story. I'm not saying it to set
Yeah,
an example.
right.
It's extreme. He now eats once in 3 days. I don't know how he does that. It's extreme intermittent fasting. He only drinks black coffee in between. He's now down to 70 kilos. And he looks actually thin. So but these are very extreme. And like you said, even intermittent fasting to such an extreme can bring its own
No,
risks.
so I would like to interrupt here, because see, now he has got down to that weight, but has he checked his muscle mass? Because when you lose weight, there's always a muscle mass also loses. Now for a patient who has lost weight by any means, now from 130, 140 he's come down to 70, he must have also lost his muscle mass. If he is under supervision and is taking his proteins properly, then it's absolutely okay. But the way you're saying he's eating in 3 days, once in
Yeah.
3 days, that's not good.
And working out is where every day.
So that's really not good, because he has to understand where does he stand in the form of percentage fat, where does he stand in the form of the muscle mass in his body. If everything is in a proper place, then it's fine. But eating once in 3 days, I would
Yeah,
not justify
he's
that. It is
yeah.
going all against the laws.
He's happy with his weight loss. He's also reversed his diabetes and brought his
100%.
cholesterol down.
See, for any matter, if you lose 5
Yeah.
to 10% of your body weight, your diabetes is going to be under check, your medicines for blood pressure is going to be coming down, your risk to heart is also going to come down.
Coming to the types of bariatric surgery. Can you tell us about
so
the types?
There are multiple types of bariatric surgery. So something called as restriction and something called as malabsorption. Now restriction is putting a restriction on the amount of food you eat. So a normal stomach, for an average, it would be around 1 to 1.5 liters. Now when you put a restrictive surgery on it, that means you take away a maximum portion of the stomach. From 1 to 1.5 liters, we keep it to 70 to 140 ml only. That is a sleeve gastrectomy, which is purely restrictive procedure. We can also put in a balloon to restrict the amount of food the patient has.
Okay.
Or if there's a malabsorption, so what you do, you make a small stomach and you attach a calculated portion of intestine and you bypass that intestine and you attach it to the stomach. So that's a bypass, wherein the food enters into the small stomach and directly bypasses 180 centimeter of the small bowel and enters into the distal part of the small bowel. That's malabsorption. So you either create a restriction wherein you don't eat that much of food, or you create a malabsorption, or a combination of two. Now why do we do this? See, ideally a person, you, me, anyone will require only 2000 calories for the daily metabolic activity. Even for sitting now, right now we require some calories.
Yeah.
So those 2000 calories are maximum. But as in when we do the surgery, a max a patient might have around 800 to 1000 calories. So the patient is falling short of maybe 1000 to 1200 calories. These calories would be taken down by breaking the fat which is already deposited in the body, and that's how scientifically they start losing weight. So for common man, you eat less, you're not hungry, you're losing weight, but you are energetic also, because the fat which is getting metabolized, it gives you energy.
Okay.
So that happens immediately after the surgery.
So to understand in layperson's term, okay, you essentially shrink the size of the stomach.
So rather than shrinking, we make it short.
Make it short.
We staple it or we cut it and we make it in a small pouch.
Okay.
So the size itself is really small, and that much food is sufficient for your daily metabolic activities. And the excess what is required is taken down by breaking the fats.
And then some of the food you said goes to the small
intestine also.
So it bypasses
the initial part of the intestine.
the initial part of the intestine, and that's the science behind it.
Yeah,
the
but
mechanism.
see, I would also mention here a caution, because you are bypassing the initial part of the intestine. You are restricting the amount of food so much. Deficiencies can occur. Yeah. So there is good important mention here about the deficiencies, because patients, when they undergo bariatric surgery or for any matter weight loss surgeries or weight loss with medications, deficiencies can occur. If these patients do not take adequate nutrition or proteins or their multivitamins, they would come back with deficiencies and they would have complications also.
Okay, so that's what I was going to come to. You preempted my question. We've seen nutritional deficiencies. These are common problems post-surgery, B12 and iron deficiencies. You explained why that happens. There's something else called the gastrointestinal, the dumping syndrome.
Right.
What is that?
So dumping is something wherein, especially which is seen in patient who's undergone a bypass, wherein you have bypassed the initial part of the intestine. Now let's say, for example, a patient has some sweets. That sweet is directly going into the small intestine, bypassing the rest part of the stomach, bypassing the initial part of the intestine. The body will react as if there is a lot of sugar inside, because it is not going through the normal anatomical route. So body will generate a lot of insulin, and because of the surgery, the insulin resistance is completely gone down. So whatever the body generates, everything will be utilized. So for simple terms, a patient having sweets after surgery, his sugars are going to go down. Now for a normal person, if you have sweets or anything, the sugars go up. But for patients who have undergone bariatric surgeries, the sugar will go down, and that is what is dumping. And dumping can be early dumping, maybe within 15 minutes to half an hour, or it could be late dumping, 4 hours, 6 hours after the amount of high carb or maybe sweets they have consumed.
What about months or years later?
No. So that dumping can be, see, we have done an anatomical change. So that food which causes dumping will always be there. So even after 1 year post the surgery, if the patient tries to eat a lot of sweets, they will experience dumping.
Okay.
So for a patient who has genuinely undergone a bariatric surgery, sugars have to be completely restricted. They can have natural sugars, they can go on sugar free, but sugar as per se should be definitely restricted, because there is no point in doing the surgery then. You are consuming a lot of sugars, you are consuming more calories. And that is the reason why you are having dumping.
Okay.
So couple of my patients, they did try to eat some sweets, but because of the dumping, they have stopped eating the sweets, because that dumping itself is so maybe a horrible experience. They feel as if they're getting a heart attack.
Really?
It's sweating, palpitations. So people on their own, they stop eating sweets.
And alcohol?
Alcohol, definitely yes, you need to avoid, because when we join the stomach and the intestine, we have taken sutures there. If you pour alcohol on it every day, you are tend to having an ulcer, and the ulcer will lead to perforation. So these complications will definitely have.
Can this dumping syndrome be life-threatening?
Dumping can never be a life-threatening situation. Alcohol causing ulcer perforation can be a life-threatening situation.
So again, I want to bring up an example of a friend who had bariatric. He was grossly overweight. He had bariatric surgery. He slimmed down, trimmed down, very careful about his diet and exercise. Sadly, about a year and a half later, he passed away. So I don't know exactly why, but it had to do with some sort of stomach ulcers and then surgery that he had to do for that. It was a very sad outcome, so why would something like that happen?
So when I especially do bypasses, I ask the history for alcoholic, the consumption of alcohol on daily basis or whatever the amount is.
He used to drink quite a bit.
So I have deferred surgeries to patients who are addicted to alcohol. Because these alcohol post surgery, see what happens, the stomach size is small. Now for someone who is addicted to having 180 ml of alcohol, with 30 ml also he will have the same effect which he used to have with 180 ml. So what happens, the small quantity giving them that high, they get addicted more. And because of the alcohol, the joint where the stomach and intestine are joined, they can have ulcerations, and that ulcer perforates. And if the ulcer perforates, then it's a perforation, it's a peritonitis, it's a life-threatening disease.
Oh gosh.
So I always do an endoscopy before I start the surgery. So I do my endoscopy on the table itself. When the patient is anesthetized, I do an endoscopy, see for the stomach from inside. After 6 months, I again put the endoscope just to see how is the stomach from inside, because they are asymptomatic ulcers. Patient will never give you any symptom that there's an ulcer inside.
Okay.
But when you do an endoscopy, you realize, okay, there is an ulcer. So if you routinely do an endoscopy or check endoscopy after the surgery, that will help to identify some problems which are not even giving any symptoms. Example is this ulcers.
Okay.
So if you pick up beforehand and you treat it, there would be no perforation.
Yeah.
Plus, we have to educate the patient over and over again that smoking, alcohol, they have to stop it after the surgery.
So it is risky. There's a lot of aftercare that has to be done. It's really on the doctor to take a good judgment of who is a valid
Exactly.
candidate.
And also, when I say that, see, for an example, a patient comes for an appendectomy, they do the surgery and they see the patient after 1 month. After that, the patient doesn't follow up and it is not required. Bariatric surgery is not like that. I see my patients for years together. And a close follow-up is very, very important, because these patients can have deficiencies,
Yeah.
which the patients will never pick up.
Some other risks. There was a study in the UK, a 2022 study of over 800 bariatric patients, which found that pneumonia and other respiratory causes were the foremost reasons for long-term mortality. Why does that happen?
So the data which you were talking about, it's a UK study which was done between 2019 to 2021 something, wherein 800 patients they follow. It's a single center study, and that also is the time frame where COVID was also there. So there were fatalities, but they were, when you see that data, when you see the results, what they commented, that if the age at the surgery is high, then the chances of problems are there. And also because of the COVID, and specifically if the patient has COPD or the patient has pneumonia at the starting of the surgery, then the respiratory problems can augment after the surgery. So that's the data, but it's an international data. We still don't have Indian data as such, which corroborates with fatality after the bariatric surgery.
Okay, you haven't seen such
No.
pneumonia.
So if you have a patient properly followed up for years together and the patient follows up nicely, then there are no fatalities.
Coming to the cost of surgery, what is it?
So we as bariatric surgeons, we were fighting for insurances a long period of time. So September 2020, government has given a mandate to all insurance companies to cover bariatric surgery, provided they have their BMI above 35, of the BMI is above 40, and the policy is for 3 years without porting. Government definitely has asked insurance company to cover the policy. So I have 90% of my patients with insurance,
Okay,
and
and
covered for bariatric surgery.
right, but what is the cost? Let's say someone
So
wasn't.
cost, it depends on hospital to hospital. I mean, my hospital, every hospital has a package.
Okay.
If there is no insurance for the patient, so then we do in packages, which is very, very low, very, very minor.
Okay.
So if I have to give the cost,
Yeah,
so
yeah.
it's probably less than a lakh. I mean, less than 3 lakhs. I mean, if
Less
you have to
than
give
3
the
lakhs.
cost, less than 3 lakhs.
That's not bad.
It's not bad. See, the amount of medicines you would be putting, or maybe the amount of medicines you take for diabetes, blood pressure, cholesterol. If you see the expenses of insulin or other medication, it goes really high.
Okay, coming to, another hot topic, the Ozempic, Mounjaro. We've spoken a bit about them. But do you see a lot of people opting for that, taking the easy way out? I've seen it. People who are not even that overweight, just going on it. A lot of celebrities using
Yeah.
it quite recklessly.
Right. So the problem is the awareness which these medicines have created. The medicines have created an awareness in a very positive way. Nobody is talking about the side effects of the medicines. I have seen couple of patients, they just want to take it because they want to lose a little bit of weight, and without thinking that they can lose it with diet and exercise also. So medicines, they have side effects. People are taking it rampantly, but my advice to everyone is, you do not take medicines without a proper guidance. You have to consult and then take the medication, because these medications can also have muscle loss.
Yeah.
You will not know whether the muscles were there from the start or no. You start with medications and you start having problems. You will never assess, or you will never be able to see how much muscle loss has happened. So before starting any medication, for all my patients, I get a body fat analysis done. I understand how much is the muscle mass, how much is the fat percentage, and then I put them on medication. And I routinely check them again to get the analysis done, whether they are losing more muscle mass. If they are losing, I put them on proteins. If they are losing good amount of fat, I put them on some supplements also. So it's always a observed weight loss with medications if it is done nicely. If it is rampant for cosmetic, then complications are there.
Yeah, we've seen a lot of like Hollywood stars, now even Bollywood, come with that Ozempic face. You know, that totally sunken, sucked in face.
Right.
But again, it's the minute you're off the drugs, you can gain the weight.
See, you have to understand how these medications work.
Yeah.
Now, these medications, they curb your hunger. I mean, they do not allow you to have more food. They achieve early satiety. So when you are on these medications, you don't feel like eating. Now, when you don't feel like eating, you don't feel like having water also. So dehydration is one very big issue with that.
Okay.
And when you are taking the medications without supervision, you will not understand how much proteins you have to take, how much exercises you want to do it. So these Ozempic phases which you're talking about, this is quite common. If you see that if you've taken the medications and have not followed up with anyone, and you're just seeing the scale decreasing on the weighing scale without understanding whether it is fat or muscle, then you are going for a negative trip altogether.
Ozempic and Mounjaro are essentially drugs for type 2 diabetes, right? So they were not initially FDA approved for weight loss. Now there are other brand names for weight loss.
No, so when these medications, so semaglutide is the active molecule in Ozempic, and tirzepatide is the active molecule in Mounjaro. Now these medications, when these were available in outside India since a very long time, we got semaglutide oral forms initially. But they were allowed to be prescribed only for patients who had diabetes and they were higher on their weight. They were never for weight loss. They were never indicated for weight loss. But because of cosmetic reasons, people were taking it over the counter also. Now what medicines have been launched in India is tirzepatide, which is an injectable form, and also Ozempic injectable form we have, which is Wegovy.
Okay.
These medications can be prescribed for weight loss also, along with patients who are on diabetes as well. So the indications have changed now. The medicines have launched with the prescription for weight loss also, chronic weight management.
Okay, and how much weight do you lose? I've read statistics that you can lose 5% of your body weight with Mounjaro within a year.
Yeah, correct. So I have read the Surmount trial. That's a trial wherein the highest dose of Mounjaro and highest dose of Ozempic, which is Wegovy, were tested for 72 weeks. At the end of 72 weeks, people had a 20% excess body weight loss by the end of 72 weeks. But you have to understand that the day you stop medications, weight regain is also going to be there.
Yeah, the risks. Again, you know, maybe it gives you a second chance.
Yeah.
But that you have to put in the hard work
100%,
also.
100%.
There's no like magic.
You can't just rely on anything that, okay, I've taken medicines, I've done surgery, and it's going to be a magic, then I start losing weight. No, it's never like that.
Yeah. You're on the national advisory board for these drugs, for Ozempic and Mounjaro. So what do? You research the side effects? I mean, what exactly is the function of this advisory board?
It's on how you start the medications, on what researches are going on. Like I said, that there is a research which is going on for adolescents also, starting with medication. So all those medications, we understand the side effects, we understand their portfolio, whom we can start these medications, or what BMI we can start these medications. So we have a lot of trials going on, the Surmount trial, the SOUL trial, what effect that medication has on cardiac metabolic activities. All those things are taken into consideration.
But you can have a pill form of Ozempic,
yeah,
right?
So the pill form of Ozempic, that is semaglutide, the active ingredient, which is available in India now. It was, I think, more than 2 years it is available in India. Yeah, we can take a pill form, but some patients can tolerate the highest dose also, and they don't have any effect. Some patients with the minimal dose also, they have side effects.
Nausea,
vomiting. Some people might have diarrhea also. So GI disturbances are there. Even with injections, the GI disturbances are there. But that only happens when you escalate the dose.
But coming to the other side effects, see, there's still a lot of research happening on these drugs. They're fairly new. So we don't know about the long-term side effects, right?
Right, 100%. So the research which has, let's say, the major contraindication for these medications are patients who have history of thyroid cancer, which is the medullary thyroid cancer. If the patient has any history in the family, we should not be starting with the medication. Pancreatitis can happen because of the medication. Now, if the patient has developed pancreatitis in the past, we should never be starting medication. Or someone who have started medication, developed pancreatitis, we should not restart medications on these patients. So there are contraindications also.
Yeah.
That's why I say, you have to take it under guidance.
Some people say gallbladder, kidney problems. I've read that there could be, problems with vision.
Yeah, so that research which has recently come up, it is seen in 1 in 1,000 patients they have come up with the research, and that was there earlier also with other medications for diabetes, but it was not highlighted so very well. It's not that only these medications are causing the side effects. Side effects were there before also, but because of that awareness these medicines have created, because of the magic pill name which the prescriptions have got, so the side effects are also highlighted.
So which is more effective, Mounjaro or Ozempic?
No, the mechanism of action is both are different. So, like I said, the Surmount trial was a head-to-head comparison with Mounjaro and semaglutide. So, some advantage of Mounjaro has been seen, but side effects are also there as compared to. So, it's the physician who has to decide which molecule is good for you, based on what is your insulin fasting levels, based on what comorbidities do you have.
Yeah.
So you yourself should never start medications. You always have to have a guided prescription.
Yeah, that being the key. Never never self-medicate.
100%.
That is, the most important takeaway of all of this. Again, it's an expensive injection. How much is the cost?
So cost of tirzepatide for a month would cost around 14,000 or so.
Okay.
Cost the lowest dose I'm talking about.
And you take it once a week? Or?
Once a week.
Okay.
4 injections in a month. For a cost of Ozempic, Wegovy we are having in India, that would go around 17 to 18,000 or so for a month.
Shot.
Yeah.
Okay.
It's a costly affair. For a month I'm talking about 4 injections. And maybe 26 to 27 you would see the rates going drastically down.
That's the future of weight loss. If
but
you can
the potency also we'll have to wait and watch.
Potency also. See, it's still, R&D is still work in progress for a lot of these drugs.
Yes.
Last question, Doc, and it's been a fascinating conversation, but last question, what do you see as the future of, weight loss? Now we have these surgeries, we have these drugs. Do you think people are just going to stop making that effort on their own? I mean, is there any other technology or surgery or medication that's going to come up?
No, then coming back to the first thing, defining obesity, it's a chronic, progressive, relapsing disease. We are fighting something which is going to come back.
Yeah.
So we have to be really thoughtful of what are we dealing with and for how long are we dealing with. For example, if you start somebody on medicines for diabetes, patient is lean, but the medicines are continued lifelong. The struggle has to be continued lifelong. So the fight for obesity also has to be continued lifelong. With the medicines, with surgeries, with a lot of technologies coming in, it is going to have a synergistic effect to curb that of the big pandemic we are fighting. But you can't say that one thing is done and then yes, you are free of it. No, you have to have a balanced lifestyle. You have to have a good dedicated dietary effort, and that's how you would be able to cope up with all the problems which you would be having.
Okay, so it's a recurring disease. You have to put in that hard work, and it's a combination of all these things that can help us control this pandemic.
100%.
Thank you very much.
Thank you so much.
Thank you so much.
Lovely talking to you. Thank you.